Change your brain, change your life. Welcome to the Ketamine Coaching Academy podcast. Join me, Bronwyn Davis, 25 years as a success coach for high performers and the visionary leader behind Conscious Ketamine Coaching Academy, as I guide you through this groundbreaking approach to healing, personal development, and empowerment. Come for the education, stay for the enlightenment, and leave ready to transform. Hello, everyone. I'm Bronwyn Davis, and welcome to the podcast Ketamine Coaching Academy. I'm here with Dr. Eshkevari, and I'm really excited to dig into this topic today because she is using and working with ketamine in such an innovative way, and I cannot wait for you to hear her. Dr. Eshkevari, I want to hear from you now. Share with us a moment that really ignited your passion for therapeutic ketamine.
Yes, first of all, thank you so much again for having me today. Really appreciate the space to be able to provide some information around this very useful medication. So I think probably for me, it was very personal. I have personal experience with the therapeutic benefits of ketamine because my own sister suffered from severe anxiety and depression. And one of the first people that actually alerted me to the use of ketamine for mood disorders was Lale, my sister. And at the time, I was teaching about ketamine in graduate school to graduate students at Georgetown University, where I was a professor for a very long time. And as I was updating my lectures, there was certainly newer information around the use of ketamine for mood disorders. I was teaching it more in the context of anesthesia because it was originally FDA approved as an anesthesia drug. And so, because I taught a lot of the anesthesia pharmacology content at Georgetown, I did used to teach about ketamine. And so, at the same time that she was bringing this to my attention, if you will, I was also finding it in the literature as I was updating my lectures. So I would say that that probably was somewhere around 2015. That really started to pique my interest, if you will, based on what she was kind of trying to push for. And she, was looking for a provider. And then at the same time, me myself seeing things on the research realm around ketamine's usefulness. And I think one of the biggest research topics that came out around ketamine for mood disorders was through the Yale University project.
Can you share with us a little bit about what you were finding out through Yale University's research? What specifically was like really getting you super excited?
Yeah, I think researchers were initially interested in Europe, at least, about the potential of ketamine as an analgesic medication. So a medication that can really help with pain management. And then as they were doing research on its effects for pain, they started to realize that, hey, wait a minute, all these pain patients are starting to report that they're having better mood, they're sleeping better, their anxiety around their pain is a lot lower. Is there something else going on outside of the pain mechanism that is really impacting the patient's mood and quality of life, if you will? And so I think at that time, Yale University's psychiatric department also was reviewing some of this research, and they then began to do research on their own around the effects of ketamine, specifically for depression. And they then started to publish their results demonstrating that ketamine is a very rapid, unlike some of the SSRIs or SNRIs that take weeks to months to really get onboarded. Ketamine is a very rapid acting antidepressant, if you will, especially for people who are treatment resistant. In medicine, we use a lot of medications off label, right? Like right now, one of the things I'm noticing in our own patients when they come in is that they're being prescribed, for example, propranolol. Propranolol is a beta blocker. We've used it for decades for patients with high blood pressure. It basically reduces blood pressure. That's its main effect. But I'm seeing more and more people being prescribed propranolol for anxiety. So because it reduces heart rate, kind of calms the system down a little bit, more physiologically than mentally, but still, the fact that it's being used is really, it's an FDA approved drug for hypertension, but we're using it off label for not me, psychiatrists and psych mental health NPs who prescribe psychiatric medications are prescribing it as kind of this anti-physiologic response, at least to anxiety. And so as I was learning more about ketamine, I became very interested in the fact that, wait a minute, here's a drug that's been FDA approved since 1970. And we've used it in the same way for decades. And here we are all of a sudden, realizing that, wait, there might be a really interesting and different way of using this drug off label, which isn't unusual. Again, like I mentioned with the propranolol, example, that this does occur and it occurs a lot in medicine. But to see a drug that I have used or I had used in my clinical practice all the time for anesthesia, analgesia, all of a sudden now have this, effect of and a potential as kind of an off-label use was really, really interesting for sure.
Can you share with us a little bit? I know you've kind of taken a transition throughout your career. You were professor, program director at Georgetown University, and now you're focusing on the clinical work and now with Avesta. Like, share with us a little bit about your journey.
I started out as a nurse in the intensive care unit back in the AIDS epidemic. And unfortunately, back then, we had no idea what it was, how it was transmitted. This is in the late 80s. And we had no cure and no way of making people even feel comfortable with it, with having it. And unfortunately, most patients did not survive. And by most, I mean, we had no survivors, honestly. I was in the intensive care unit when people were kind of at the end of life and we were trying to support them. And really, no one survived the terrible disease. And, as I was working as, a young nurse and a lot of patients were young like myself, I became a little bit disillusioned with the fact that I felt at the time that I wasn't helping people. I felt like I went into this very noble profession, what I thought was a noble profession, because I wanted to help people, and I really wasn't. People were dying on my watch all the time, and there was nothing I could do. But one of the things that did interest me was that the patients that were having pain in that unit, I could at least provide them with some pain relief. At least that's something that we could, so symptom management, if you will. So
Yes.
I did become very interested in pain and kind of the pain medications and that side of nursing. So I ended up becoming a nurse anesthesiologist. I don't know how much you know about nurse anesthesiologists, but we comprise about 65 to 70% of anesthesia in the country is done by nurse anesthesiologists. And almost 100% of rural anesthesia is done by nurse anesthesiologists. So we are a big component of anesthesia practice in the country. And in fact, anesthesia was a nursing field to begin with. And then as it became more lucrative, I think, at the time, gender played a role and men took it over, and the field of anesthesiology was born, mostly from the medications that were found by dentists, believe it or not. So I became a nurse anesthesiologist and started practicing at the Washington Hospital Center here locally in DC as a cardiac and trauma CRNA or certified registered nurse anesthesiologist. And I was there for a couple of years and then recruited to Georgetown to do the same practice. And when I was there, I had an opportunity to teach in the nurse anesthesiology program. So I began to teach there, and and then in 1999, Georgetown University sold the hospital to MedStar Health. And at that time, the dean of the school offered me a full-time position. The students really liked my lectures and the way I taught. And so I took her up on the offer to switch to the university side solely. So I started being a full-time professor, obtained my PhD in physiology and biophysics, doing a lot of research on chronic stress, depression, and anxiety. And so I remained there for 25 years. I still held a clinical practice on my own. I never stopped practicing. I, would practice in private practice, doing either orthopedic anesthesia, a lot of GI anesthesia, some plastics, and taught full time and did research at the university. And then right around 2017, 18, I was approached by a couple of colleagues who were much more entrepreneurial than I was. And they asked they knew I taught ketamine at the university. And they asked if I had heard about ketamine's utility in mood disorders. And I said, yes, of course, I teach it. So, yes. And they asked if I could help them develop the protocols and the language for their website and join them in opening a ketamine infusion clinic for mood disorders. I became extremely excited because this is literally a year and a half or so after Lale had asked me if I knew a provider, and I didn't. And here are these guys saying, hey, let's do this together ourselves. And so I became super excited. We opened our doors in 2017, 18. And then my colleagues wanted to kind of take the infusion clinic in a very different direction, more pain management, more doing some alternative modalities, if you will, that did not have full FDA approval. And because I was a university professor and kind of had built this career around evidence-based practice, doing research and teaching all of that, I didn't think that their mission and vision was aligning with mine. So decided to kind of part ways. And that's when I opened my own clinic, Avesta Alternative Care. And have been kind of running with that, doing mostly mood infusions, some pain infusions as well, using ketamine. And then in 2019, when the FDA approved the S-enantiomer of ketamine, Spravato or S-ketamine, specifically for patients with treatment-resistant depression. We brought that on board as well. And we became, if you will, a full-service ketamine provider. And then in 2022, I became eligible to retire after 25 years of service at Georgetown. So I took that opportunity to take the retirement, and I felt like I had had a good run at it at the university. I built the program to numerous clinical sites, highly ranked in the top 10. So I thought I'd achieved what I'd come to achieve there, and like in a relay, turned the baton to the next in line, who was a student of mine many years back, and ended up opening multiple locations for Avesta and partnering with Deborah Tan and her group, who really helps me to increase access to this wonderful medication by trying to go in network with some of the insurance carriers, trying to go in network with the Veterans Administration. So we are now in network with the VA. And we definitely want to increase access to people who can afford it, because if the infusions can be expensive, but the Spravato we can at least provide to Medicaid patients in Virginia. So we just went in network with Medicaid. So we're very excited. We're excited to expand and really bring this incredible modality to more and more patients.
I love that. You've had such an illustrious career. So thank you so much for sharing all that with us, to really give us that background and your passion around this amazing healing modality. What have you found in your practice as far as the protocols and the use of ketamine when it comes to treating the various mood disorders?
Yeah, so the protocol that we use is fairly standard across the mood disorders. And I'll tell you, we usually do the treatments, at least for the IV, and I'll get into Spravato in a moment, but the IV is we usually recommend twice a week for 3 weeks. And somewhere around treatment 5 or 6, patients talk about a switch that turns to get flipped for them, where they really start to think about things very differently, whether it be their trauma or the way they react to it, where they're not as reactionary, where they can really kind of have a paradigm shift in the way they think about things and they react to things, and really building better coping mechanisms. And then as they move from that intense twice a week for 3 weeks, 6 treatments, we move them to a maintenance phase where we slowly taper the patients off. So they might come back once a week for a couple of weeks. And then from there, we do, um, you know, depending on the patient, then we move them to every other week, like a biweekly cadence, then slowly to monthly. And I do like people to stay on a monthly infusion cadence for about 3 to 4 months, really coming back at those receptors on a regular basis. And then from there, most people graduate, if you will, to boosters only as needed. Now, I'll tell you, there are some very important components to the protocol. And I always tell patients that it's a tripod. One of the most important in my mind is psychotherapy, working with a therapist that can help the patient integrate the things that come up, help the patient integrate almost this new brain and new way of thinking, really help the patient to understand coping mechanism that really serve them well. Sometimes all of us humans, myself included, build coping mechanisms that may have helped us as children, especially those of us exposed to trauma. But as you get older and your environment changes, you don't need those coping mechanisms. You can absolutely pull back the emotional reactivity. You can pull some of that back and learn new ways of coping. And I think that's where a really good integration therapist is so instrumental. So that's the number one recommendation. Once the induction, the 6 intense treatments are done and we're starting to move to maintenance, we talk to patients about the importance of continuing psychotherapy, building those on, the foundations. And then we do talk a lot about the importance of nutrition, making sure that the patient is taking enough omega-3s, enough complex carbohydrates and proteins and vitamins, all the B vitamins, if you will, to support the new neurons and connections that we've built, this new neuroplasticity that we've built with ketamine. And then the third, and one of the more important as well, is the importance of building a daily habit of movement. I'm a physiologist. So for me, I think good nutrition and daily habit of movement alone for patients who don't have a mood disorder will keep you young and healthy, your brain young and healthy. Now, if you add a mood disorder, that will do wonders when you put it on top of the neuroplasticity we build with ketamine and really good therapy that can help you kind of advance in your wellness. So it is kind of a comprehensive protocol, if you will. It's not it's not a one and done or several and done. And we do have patients who, we do the protocol on and they don't come back ever again. And we touch base with patients every 3, then 6, then year. And when we get to the year and they're doing fine, we don't want to bother them. We're like, okay, we're here. And I do have some who come back for boosters, but some patients don't. They do really well and they kind of start to learn to manage their chronic illness. So yeah, that's the IV protocol, if you will.
Do you make it a prerequisite for them that in order to work with you, that they do have to have some sort of a therapist or a coach or someone who is helping them with that integration?
Yeah, we do really want patients to have a therapist and or a mental health provider or a coach, if you will. Um, Sometimes patients that reach out, as you wouldn't believe, but as acute or as severe as their diseases might be, and that's where or their symptomology might be, they still don't have, a therapist that they're working with, believe it or not. So in that scenario, we introduce them to our resource page, which has quite a few therapists on it, some that take insurance, some that don't, some that specialize in OCD, others that specialize in teens, it's kind of a full gamut, if you will. And we highly recommend that they reach out to a therapist and then let us know who they're seeing because we're very collaborative. And then we reach out and start to talk to either the patient's own therapist or, of course, after receiving an approval from the patient, or we refer them out and request collaboration so that we can kind of keep in touch with the patient and their therapist, at least while they're in the ketamine protocol. So, as you know, we can't make people do anything, and that's okay. But we highly encourage, and it is our preference that patients are in therapy, at least while they're going through the ketamine experience.
And what do you notice about those who are doing the integration therapy and coaching, as opposed to those who maybe say, "Nah, I don't need that," or they don't get
Yeah,
connected with someone?
yeah, to be honest, I think most of our patients either work with a therapist or with our ketamine coach, at least to begin, and then we graduate them to their own therapist. So I don't know if I've noticed a difference in the few that don't have a therapist, but I'll tell you just anecdotally, and this is just based on observation. So I haven't done a comparison, if you will, an official or a, more formal. I do think that patients who really, kind of take it all together as a package, like, okay, I'm doing this thing, but it's not a magic pill. I'm doing this very hard work in the ketamine journeys, and I'm working with a therapist, and yeah, I'm starting to, go for a walk every day, and I'm minding my diet. It sticks a lot better in my observation, and especially people who have patients who have someone that they are able to integrate the work with. I do think it causes a bit of a more stickiness. Now, I'll tell you, there was a recent research, and I wish I remember where it was published, but there was recent research where the researchers compared a group that had ketamine alone to a group that did ketamine and therapy. And they found that on the PHQ-9 and the MADRS, I think it was the MADRS that they used, scale, that there was no difference between the two groups in their depression scores on MADRS. But I also think that we're at a very interesting point in the way, in the trajectory of the way we assess patients with mood disorders. I do think that sometimes we ignore some of the more quality of life aspects, if you will. And so I'm not sure if you were to compare the two groups in a research study, if you will, the ones that do ketamine alone versus ketamine and therapists. And if we had a new tool that not just looked at kind of these numerical values that we get from the PHQ-9 or the MADRS, some of these validated tests, but also dug deeper and looked at, loneliness or, some of the more quality of life, like, okay, how are you incorporating what you're, some of those questions, I bet you the results would be a little bit different. So I guess what I'm saying is I don't know if we still have the validated tools to measure the difference between the ketamine only and the ketamine and therapy groups. I don't know if I'd be the best person to design that because I think I'm a little biased towards thinking that if you combine it with therapy, good diet, and exercise, you're going to be a winner a lot faster and a lot stickier than if you did the ketamine on its own. But again, I'm a little biased as a physiologist that I think those things together work very well together.
Absolutely. I wholeheartedly agree. I've seen it as well and love seeing how my clients just have such a greater impact and they're able to move forward much quicker with it as well. So
Yeah, yeah.
I I totally agree with you on that. We are going to take a break, Dr. Eshkevari, but I want to thank you so much for being here. I'm enjoying this thoroughly. And when we come back, I really want to talk to you further about your work with veterans, as well as you brought up some good points about neuroplasticity. So I want to get back into that as well. This podcast is sponsored by Conscious Ketamine Coaching Academy. Step into the future of mental wellness. I'm Bronwyn Davis, founder of Conscious Ketamine Coaching Academy. This isn't just a career, it's a calling to guide deep, meaningful change by integrating transformative coaching with therapeutic ketamine, a cutting-edge healing tool. We empower our clients to heal and grow beyond their expectations. Ready to make an impact? Click below to learn more. Welcome back. I'm here with Dr. Eshkevari. I am so excited by this conversation because we've just been really exploring the benefits of therapeutic ketamine in such a unique way. And I want you to now, if you wouldn't mind, talk to us a little bit more about the work you're doing with veterans and first responders. I know that's really very close to your heart as well.
Avesta is part of a group. We are called the Veterans Mental Health Leadership Coalition. The coalition is made up of mostly veterans who themselves have experienced severe PTSD, severe mental consequences of having been in the front lines, if you will, at different war zones, and as well as other providers and researchers who are very interested in the population. It is led by General Steele. He is kind of the leadership of our group. And we have testified at Congress. We are very kind of boots on the ground at the state level and the federal level, really trying to expand the way that the federal government and the local state governments view the access to alternative care for veterans. Because right now, a lot of veterans, for example, go to Mexico to do an ibogaine experience. And ibogaine is a substance. It's similar, but not the same as psilocybin. It's natural, and it's used in ceremonies in Mexican culture. The Mayan cultures, and it's still around, and people still use it, kind of in that journey. Or ayahuasca is another one that comes to mind. But what ends up happening sometimes is that those experiences may not be safe, and veterans have come back with some complications. And so we really want regulators to understand that the current system isn't necessarily being it's not necessarily open enough to allow the veterans to experience alternative forms of treatment. And that includes ketamine, and that which is right now the only FDA approved psychedelic, if you will. And it's not even a psychedelic, it's more a dissociative, but still, we are trying to open the minds of legislatures to at least allow research. Because if we don't have the research to say this works and this doesn't, and what's even the safe dosing for it, or what's the best route, and when we do these treatments, who should be present? Should it be the medical person like me who knows how to rescue someone physiologically, and a therapist? Should it be what is the model that we want to go after? So really, our coalition is built around increasing the research around some of these alternatives, but also increasing access to ketamine, which is currently FDA approved. And so the FDA not the FDA, sorry. Well, they're both FDA. The S-ketamine and IV are FDA approved. One for anesthesia we use off-label, one for treatment-resistant depression that was approved in 2019. But aside from the ketamine world, there right now is no other FDA approved psychedelic, if you will. And so the Veterans Administration has accepted both the IV and the Spravato as treatment options for veterans. So I'm really excited that that has happened. That happened quite a few years ago. And now we're working on the Veterans Administration hospitals to refer patients out to clinics that do Spravato and that do the IV. And so that, as you can imagine, is also very close to my heart. So very excited around that. And then in Virginia, hopefully working with the legislature to allow us to conduct some research around these important new, whether it's MDMA, psilocybin, ibogaine, to at least allow us to begin to conduct research so we know what's the safest, best dosage, what are the mechanisms of action, what are the reactions, and the contraindications. So that's the work that we're doing with veterans. On the front responders or first responders or frontline responders, we are partnered with a group in Virginia called 1010. And what they do is they provide the therapy. And so the patients access the first responders, police officers, firefighters, EMTs, military. They basically access the care through 1010. They come in seeking therapy and ketamine, and then we work with 1010. So they do the therapy, we do the ketamine protocol, and work very collaboratively as best we can to really help those patients. So that's our work around first responders and veterans.
I also know firsthand how first responders, as much as they need it, especially like firefighters, it's hard to get them to kind of cross over into even asking for help or admitting they need help. Have you noticed that as well? Like, do you notice that they're slower to kind of admit that, wow, something I really do need help?
Yeah, I think it's kind of the nature of the way they're wired. First of all, they're not about themselves, right? Anytime you become a first responder, you really are the kind of person that wants to jump in and help others. So then you yourself are kind of, just by nature of who you are, your personality or how you're wired, you're not really looking to take care of yourself. You're looking to take care of others. And so there's a lot of self-neglect, not recognizing symptoms that you would recognize in others, or maybe even recognizing it, but saying, "Oh, come on, let me pull myself up by my bootstraps and get back to work and helping the person next door who is struggling with this fire, or saving a life." Or so I think by nature they're not the kinds of people who seek out help. They are the ones that usually help our care and are the caregivers. So I
Yeah.
think that's the first thing. And then the second thing, I think when it comes to ketamine, I think, sometimes, especially the EMTs and police officers, maybe they've seen people under the influence of some really bad drugs, or the side effects or the untoward effects of people doing them inappropriately without you being there, a therapeutic person being there, or doing inappropriate doses, or instead of doing it in a clinic, getting it on the street, whatever they've taken, the people that they're encountering. So I think that instills a healthy fear and a healthy level of respect. And so there's kind of a trust issue with the substance itself, So I think and it's probably even more facets to it that I don't know and I can't even, imagine. And this is all conjecture on my part, but I'm thinking those are probably the two main reasons why people wouldn't tap into something like ketamine. And I think if you and I think about it from our own perspective, because you're a caregiver and I'm a caregiver, we would that would probably those would probably be the reasons we wouldn't necessarily say, "Hey, I have a problem," because we're designed to help other people. And I've seen, what some just in my experience as a trauma CRNA, just having seen things that people have experienced, I would probably be shy about trying anything myself had I not known about the medication ketamine. So I think those are probably, I would say, the reasons why.
Those are really good points. I want to make sure before we wrap up, I really want to hear. I know you offer a very unique and comprehensive therapeutic ketamine package. Can you share with us a little bit about that and really some of the transformation you've been seeing with your patients because of it?
Yeah, sure. So, like I mentioned, we do have kind of our traditional IV ketamine protocol where we really, and the Spravato is twice a week for 4 weeks. That's what the FDA has recommended. So that's what we do. And then once weekly for those patients. So outside of kind of that comprehensive, Spravato or IV, we also have partnered with Dr. Bregman, Benjamin Bregman. He is a psychiatrist in the area in Washington. He is phenomenal and has his own psychiatric practice. We kind of started talking through, and actually it was his idea. He kind of brought to my attention that he sees a small subset of patients that don't have a diagnosis, and he's a psychiatrist. So if anyone's going to diagnose them, it would be him. And he's phenomenal at what he does. But what he and his mental health nurse practitioner, Heather, have brought to my attention is that they see a subset of patients that don't have a diagnosis, but they feel very stuck. And they feel like, what used to bring them a lot of joy, they're not necessarily depressed or anxious or any of that. They don't have an official diagnosis, but they're at a point in their lives where the things that used to bring them joy don't necessarily bring that same level of joy, or they've lost a little bit of the zest and they're feeling stuck on one or two areas. Maybe they're looking at retirement and that's really scary, or they're moving, or they're in the midst of starting to talk to their long-term spouse about a divorce. So there isn't an official diagnosis, but they're feeling stuck. And so this program that Dr. Bregman and Avesta are partnering on is that he meets with the patients pretty intently, him and his team, and they start to talk about, what some of the issues are, what is at the crux of it. Then they start talking about ketamine as a way of building neuroplasticity and kind of starting to think about, causing a little bit of a paradigm shift. And then the patient comes in with Dr. Bregman or one of his staff, usually him or Heather, his psych mental health nurse practitioner. Either one will come in, they'll sit with the patient in our clinic as we do a 1 hour infusion. And the dosing and everything is determined by the nurse practitioner based on the patient's weight and kind of in real time. And then the patient goes back to Dr. Bregman. He does another, few sessions with the patient, starting to really integrate and starting to really come at, okay, now let's get even deeper. So that's a couple of weeks. And then the patient comes back to Avesta with Dr. Bregman for a 2 hour infusion, a much more intense, with Dr. Bregman or Heather being there supporting, but we do a 2 hour infusion, really coming at the receptors again. And then the patient, again, the following couple of weeks works with Dr. Bregman to integrate everything. And so this is how we've built it. And then the patient can have the option to come back for one more 2 hour session if they feel like that's necessary, or if we unmask a diagnosis, then they can come back for the Avesta full protocol. But that's kind of the program that we've built right now with Dr. Bregman's group. And we've only just started this about, I would say, a couple of months. We've taken, one patient through it so far. So this is in its nascent stages still, but we are very hopeful and they're doing pretty well. So I think this is more probably along the lines of therapy, with the medicine helping to really break through some connectivity and manner in which the patient thinks. So I'm excited to see what we get. And then depending on how things go, I wouldn't mind designing another clinical research project on it, if you will. We just finished one last year and published it in Psychiatry Research. So I still do some research with Georgetown students. So looking maybe to put this through a formal research, but once we get more patients and really look at what we get, because again, Dr. Bregman has noticed the subset of patients that don't have a diagnosis, but may not be where they want to be.
Exactly. And I love that you are one day going to be doing the research around that. I have been working with that subset of clients for about the
Oh,
past 4 years to help them get unstuck. And
oh, that is
so,
so cool.
yeah, I'm very familiar with that subset. And
That
it's
is so cool.
and it's amazing to see their transformation.
Yeah, I bet. And I bet it's quicker than people who have an official diagnosis whose, receptors or neurotransmitters may not be optimal until they really get the full protocol. So I think that's really exciting. I'm really excited about it.
What do you see the future in therapeutic ketamine? If you could just, in a few words, a few sentences, how do you see it unfolding over these next few years?
Well, I wish I had a crystal ball and I could tell you how I see it, but I'll tell you what I hope for. I hope that I hope that the Centers for Medicare and Medicaid starts to really look at all the available data around ketamine for mood disorders and starts to really allow patients to be reimbursed for it because it works really well. There was a head-to-head study with ketamine versus ECT, and the study showed that ketamine, which is a lot cheaper to do and a lot less invasive, worked just as well as ECT for people with severe depression. So, we have so much data now over the last 15 years that has really shown this drug to be very useful. And, that's where I really hope we will be in 5 years, where the barriers to patients getting into the treatment and getting reimbursed is better because I definitely don't want this to be the kind of treatment that only people that can afford it should have access to it. I feel very strongly about that. And that's why we went in network with the VA. That's why we've gone in network with Virginia Medicaid, because we want to increase access to to ketamine. And then I'll finish by saying I really hope that that opens up for IV as well, because we're seeing more and more, at least anecdotally, and I think there was a recent study that was just published in Journal of Clinical Psychiatry that showed that the IV is much more superior to Spravato. So the one that the FDA approved is not nearly as fast and as effective as the IV. So, it's, I think, about time that insurance companies start to cover the cost of the IV, which again is a lot cheaper than Spravato, because it's an old drug. It's off patent as opposed to Spravato, which is pretty expensive. So that's my hope for the future of ketamine. And then in the space, my hope is that we have enough good research that we can start to get FDA approval for psilocybin, for MDMA, some of these other very useful, beneficial drugs that we hopefully will have more data and that can show that there is room for, other types of medications other than SSRIs and SNRIs where we've lived for the last quite a few decades and they're not as effective. So that's my hope for the future.
Beautiful, beautiful. And thank you so much. How can our viewers get a hold of you or at Avesta? What is the best way to find out more and connect with you?
Yeah, sure. So I think the best way is probably our website. There's all the locations are there, all the different contacts are there. Our website is avestaketamineandwellness.com. We are also on Instagram. Our handle is Avesta Ketamine Wellness. And yeah, so I think probably the website has all of our information. You can access it there. We do a free phone consultation for anyone that reaches out. We do a pretty thorough initial intake. That's all free. We're happy to answer questions. We don't charge people for being curious. And so we're very happy to do that. And then our nurse practitioners will review everything. And then depending on why you're reaching out, your diagnosis, who you're working with, they will approve your treatment and then we'll kind of go from there. But that initial getting in the door, we try to make it as easy as possible and we don't charge people for the time.
How many
Yeah, thank you.
locations does Avesta have?
We currently have 4 locations. We are located in Bethesda and Columbia, Maryland, so 2 locations in Maryland. We have a location in Northwest Washington, D.C., kind of right between Logan and DuPont Circles. It's on the metro. We have a location in Tyson's Corner as well in Northern Virginia, also on the metro, on the McLean Metro, the Tyson's Corner Metro. And we also have, we're just building out a new location in Norfolk, Virginia, because it is very close to the VA. And like I said, we have gone in network with the VA, and we really want to bring this to patients where they are, because as you know, patients can't drive after receiving ketamine. So we really want people, we want to increase access as much as possible, lowering costs, lowering the burden of patients getting to and from their provider. So we're just starting to build that clinic in Norfolk.
Dr. Eshkevari, thank you so much. This has just been a great conversation. Thank you for being such a wonderful guest.
Thank you so much for having me, and a really great success to what you're doing. Really appreciate what you're doing in the community as well, spreading the word and with the work that you've been doing. So thank you.
Thank you.